It's 1 o'clock and it's Friday. Put your crunchy bars down. Resist opening that additional can of cider. The time has come for you to give this your absolute undivided attention, because today is the IHSCM Digital Technology Roundtable event. My name is John Wilkes. I have the privilege of being the Chief Executive of the Institute of Health and Social Care Management. But my position doesn't really matter today, because I'm just here to introduce you to the fabulous people who comprise today's roundtable. So in order, we've got Shane Tickell. Shane is Chief Executive and founder of Voror Technologies. We have Issac Theophilos, who's the owner of Outstanding Care Homes, which is a consultancy to help you achieve, I'm assuming, outstanding ratings with our beloved CQC. We have Katherine Church, and Katherine is Associate at Ethical Consulting and Ideal Health. And contrary to what you might have seen when she was drinking, she hasn't yet opened the cider. I'm quite convinced of that. We have Rachel Murphy, the fabulous Rachel Murphy, who's a non-executive director at Careology. Great name, by the way. And we have Rahul Goyal, who is a lover of acronyms. He's CCIO and GP at ADHDS. I'll let him explain a little bit more about that in the fullness of time, but it would be improper of me to go on without introducing you to the queen of the IHSCM Digital Tech Roundtable, who is, of course, June Hall. June is going to be chairing today's exercise. June, I'm going to hand straight over to you. If you don't mind, those of you in the audience, we will try to get you involved with some Q&A towards the end. But we've got quite a lot of stuff to get through in terms of the content of the roundtable discussion. So I'd be grateful if you could mute and let June and her roundtablers contemplate the big questions of the day. June, over to you. Thank you.
Welcome, everybody. And I think this is one of the first meetings we've had where we've combined both the healthcare and the social care digital groups. So welcome to everybody. Thank you for your participation. And if you've got any burning questions or any comments, please put them in the chat and John will pick them up. So today we're talking about digital health and digital technology in health and social care. And I'd like to kick off with one of the big questions is, every other industry seems to have been revolutionized and modernized using digital technology, and it seems to have happened at pace in industries like retail, banking, travel and transport. I mean, most of us book our holidays online now. But why hasn't the healthcare industry been revolutionized the same way? What unique challenges does it face, and what's stopping us? So I'd like to put that question to Rachel first, and Rachel, get your opinion, because you run Careology. You've obviously got a lot of experience in the healthcare industry, and it would be lovely to hear what your opinion is. Thank you.
Brill. Thank you, June. So big question. I'm glad we've started small. I think there's two, well, from my perspective, two sides to this coin. I do think that we have started to revolutionise. If we look at things like the NHS app, we've now got 22 million people starting to use that. However, I will caveat that with part of the reason I think we've been so incredibly slow to move in the right direction is because there is public opinion that the NHS is one organisation. And that was a trap that I fell into myself when I first joined. The reality, of course, is it's 22,500 different organisations and plenty more popping up, ICS, ICB, as we speak. And I think the complexity there is around how we share data between those organisations. And the crux of that is, as users of this service, as patients, I have a really strong view that we should own our own data and we should donate that data into the NHS. But the complexity, some of the complexities around interoperability seem to have stalled kind of progress entirely in that area. And what I mean by interop is, you know, the handshaking and the talking between the different IT systems. So just two sides to the coin there. I do think progress is being made, but I'm the eternal optimist, June. So I think I better caveat that. But I also think there's a hell of a long way to go. And I don't think the challenges with interop are necessarily technology. I think they are probably more culture and resistance to change. So on that note, I will pause myself and go back on mute.
Thank you. That's really interesting. I mean, and interoperability and integration, if we wait for that to happen, I think we'll be waiting a long, long time. I mean, because we've talked about standards, you know, applications conform to standards, but what about just doing something simple that adds real value to the users, you know, killer app, they can't do without it. What do you think, Issac?
Oh, thank you for having me, June. In terms of, I can speak on behalf of care home sector because that's where my experience comes in. The biggest challenge we face, although you mentioned that other sectors are being disrupted by technology rapidly, one of the reasons that the healthcare or social care is not advancing as quickly as we could is because we are dealing with humans, which means we have to go through the process of consent, sharing information, data protection, all those sort of elements needs to be implemented. The second, in the care sector, it's a very diverse sector. There's no one fixed solution for all. There are different kinds of providers. In terms of financial viability, it varies. In terms of ownership status, it varies. And there's lots of reasons why they can't really implement. And on top of that, we also have staffing shortages and day-to-day operations. So when I work with care homes, or even myself, I own a care home. So I understand very well that in order to implement a system, you have to dedicate time in order to do that, which we don't really get because the day-to-day surprises that's coming out of operations is more critical than implementing a new system, which may solve the long-term problems. So staffing, dealing with human data, and then the diversity of the sector.
Okay. Okay. Yeah. I agree with that. I agree with staffing and everything. But surely other industries have had to cope with the data issue, though. I mean, Katherine, I can see you're champing at the bit to get in. Please. Go ahead.
Yeah, well, I actually come from a banking background. I only came into health and social care less than 3 years ago. And I made the mistake that Rachel made. So I think Rachel's spot on. I thought the NHS was one thing. If it had a blue lozenge on it, it was the NHS. And that was a massive mistake. I was the Chief Digital Officer for Surrey Heartland's ICS. And I also thought ICSs were a real legal thing with the ability to bring people together to address some of those issues, data sharing and interoperability. And that also wasn't true either. So I think there's something about the complexity of the landscape. I think there's something about budgets and budget setting. So when I was in the NHS, the budgets were year to year. You get massive chunks of funding for really short-term projects. There's no continuity of funding, and you can't move to a digital environment on short-term bits of funding, however massive that funding is. But if I could just be slightly more controversial, and I think, Rachel, you touched on this and I'm probably a bit more polite than I'm going to be, there's a massive cultural issue about sharing. There's a massive cultural issue about defending one's territory. And there's massive cultural issues around protecting your environment. So I'll just think of hospitals that I've worked with that have 20 tiny little contact centres within the hospital because nobody wants to share their patients and nobody is willing to let go of a tiny bit of control so that you get something that's going to work better for the patient. And I think those cultural issues have come because of the way the NHS has been funded, the way the system has set people up to fight against each other for funding. So it's all completely natural and understandable. And the final point I'd make is what happens at scale and what happens at location. And the NHS app is a brilliant example of what the NHS can do at scale. So if everybody got behind the NHS app and we didn't have multiple GP apps and multiple hospital apps and multiple other apps, then actually you could really, really do something that is super, super powerful. So I would say centralize a lot of this. And I'm sure people are thinking national programme for IT, but I think if we all got behind one killer app like the NHS app, we could really move the dial massively.
Thanks. That's brilliant, and it's a great segue into bringing in Rahul, actually, who is a practicing clinician. It'd be great to get your view. Centralisation, just as you say, you know, after the national programme, nobody wants to go there. But you know, in big organisations, that's how they operate. Everything's centralised and it's top-down driven. But as you said, the NHS is made up of lots of different organisations, and they've each got their own autonomy, shall we say. So Rahul, it'd be great to get your view.
Thanks, June. Interesting chat. So I wear two hats, a practicing GP, previously trained as an ophthalmologist, so I also understand a bit of secondary care, and clinical strategist for digital health, you know, shared care records, EPRs and such. I also have and I'm also very lucky that I work in the UK and the UAE, Abu Dhabi, Dubai government. So I lead the project for the shared care summary record in the UAE, in Abu Dhabi.
All right.
I can see the difference because I straddle both those geographies, if you like. The speed of execution, the approach taken for that execution also, which touches a lot on change management. Now, change management and working at pace happens when there is a demand. I don't feel as a clinician in the NHS, I was empowered enough, or anyone was asking me the question, what should we do to improve your workflows and your work lifestyles? When I went to the UAE, those questions were being asked regularly. And you become part of that sort of critical movement. I think a big change is required why one geography will be a laggard and the other would be going at pace. The change in tack, the top-down approach might not be a bad thing at times, especially for an organization that is so disparate like the NHS. Because if you have a national agenda and there are fixed guardrails and guidelines, we have the room to maneuver between them. So you do have the autonomy to have the guardrails and to maneuver between them for your case study, and at the same time work at pace towards that common goal. If I was to put it down, I would say we haven't yet won the hearts and minds of the clinicians who actually do the dirty work.
Yeah.
We need a lot of work on that. And that's the reason why we are slightly laggards compared to other geographies, personally.
Thank you, thank you. And it has been a bit like that in NHS. If it ain't broke, why fix it? But I think we're getting to the stage, you know, after COVID and the waiting list and everything, that everybody has begun to recognise that the NHS really does need some help. So, thank you for that. And you do see that in other countries, especially countries that are not as far ahead digitally as England, where they're building new hospitals. They've got the opportunity to put in new systems and devise new ways of working, whereas we're trying to retrofit everything here, I think. Shane, what do you think? You've been around a long time.
Thanks, Jim.
Why no, relatively speaking,
about 20. Yeah.
About
30 years. That's right. So about 25 years in the electronic patient record space. I suppose the privilege that I've had is I've travelled a third of the world. I've travelled to every corner of the UK and Ireland, and I think I really love what Rahul said about the fact that, you know, why don't we ask the people at the front line really what's the matter? They're the ones with the answer and work backwards from there. That might seem obvious, but it's really hard. I think Katherine and Rachel have made some exceptional points that I've really come to the same conclusions of. I'll come back to those in just a second, but I think we did start quite early with technology in healthcare in the UK. So we digitized things like pathology and primary care. And actually, you know, most recently I go to big city hospitals and they'll say, look, this isn't about implementing shared care records. My phone system doesn't work. My key card system is 30 years old. The supplier doesn't even exist anymore. So, you know, when we heard last month that we're going to get a brand new telephone system, people might think, why? But that's how basic it is. So there is an element of, look, if we can't get order comms right, or we can't get telephones right, actually doing some of these big, sexy projects of a shared care record or a national federated data platform, actually, you know, there's such a gap with that on the front line. So I think the centre has some really important roles to play, but I talk a lot with the centre. I do a lot of work with them, and actually they're there for guidance, and I'd say they're there for money, but do not wait for, I think there was 9 strategy documents came out in 4 months between March and July this year. Don't be waiting for any of them, because none of them are overly ambitious. I think people do know what their challenge is locally. The 22,500 organisations, the big cultural appeal I've got to people is to be open-minded, because as I've traveled around the world and as I've traveled around the UK, the one thing that is so common is people say, nobody understands what I do here. No one understands what this hospital's like. No one understands what this GP surgery is doing and what it has to cope with. Actually, about 80 to 90% of what everyone's trying to achieve, no matter the demographic, whether it's East London or whether it's Grampian, actually isn't that dissimilar, but people are at different stages. But the open-mindedness and the fiefdoms, and the fiefdoms are at the top, some big chief executives of big organizations. But at the front line, you go back to 2004, Lord Carter did his review of pathology and said, look, 8 bases, centralize. You haven't got enough staff, you haven't got enough skills. Release the pressure on the system and actually help each other. We're 18 years after that report, and actually a lot of it just hasn't been implemented yet. And it's the same today with an awful lot of things about, hang on, what about my job? So open-mindedness. And the other thing I'd say about technology that really threatens people, so today we've got 9,000 data analysts in NHS England. We could replace 8,000 of those people's work with technology that exists right now today. However, I wouldn't say get rid of the 8,000 people. What I'd say is get them to do something more advanced, and let's think forward. So that open-mindedness to me is the call I've got to everybody is, please start to be open-minded. Don't think all about how it's been done in the past and that I'm different. How can it be in the future? And let's learn from each other.
Yeah, great. I'll come back, Rachel, I'll come to you in a second. I just want to bring Craig in, who's here. So, I mean, we've got the added challenge now of we're trying to integrate both health and social care with the ICSs. I mean, should we have ring-fence budgets, technology budgets? Would that help? I mean, so that we're getting off on the right foot. I mean, Craig, you've worked in healthcare for a long while. I know, yeah, and it would be great to hear what you think based on your experiences.
I think we've always talked about ring-fence budgets and this IT project and that IT project. Actually, there's no relevance to it, and that I think often has built the gap between the IT department, the technologists, and what's keeping the chief exec awake at night. So, tying in what Shane says, they've all the same problems, but I've been a CIO of a large teaching hospital, turning it around. To get things off the ground, to get the funding release, to get the energy, you need to make it relevant to the people who are in leadership positions as well as the frontline staff. If you can make that bridge, it'll work. So yes, we do need funding. We do need common standards. And I now work for a Swedish company coming into the UK, and I can assure you the UK is the most challenging country in the world to enter as a new technology company. Yes. In terms of, it's fantastic in terms of what we've done. But the only way I sell now I'm on the other side is to make it relevant to the people who make decisions. And if we make it relevant, it doesn't matter about ring fence funding or anything else, they'll find the money if it's relevant to them, and it's going to help them sleep better at night.
That's interesting. That's interesting. Rachel, I can bring you in now. I notice you put something on the chat.
I was just reinforcing the point, really, June, that Shane was making. So I think it's less about, getting rid of lots of different people, but it is more about retraining and reskilling. We had the same challenge at NHS Digtal, awash with kind of old school program managers, and there's a need there to redeploy and redeploy to the front line to actually get some of this stuff moving. But I was just reiterating Shane's point.
Thank you. Brian Donnelly's come up with a question for Rahul, which is interesting, actually. What about outcomes in the UEA? Do they have better outcomes? Can they demonstrate better outcomes than what we have in the UK?
Thanks. So thanks for the question, Brian. It's an interesting one. We actually, at the process of measuring the positive impact, what we have done is we have tried to measure on two aspects. One is feedback from our clinicians, because we are more than 35, well, 30, almost clocking 35% adoption levels at the moment. Our benchmarks from the US for a shared care record or a health information exchange are about 15%. So we're doing much better because of the change management. Most of the clinicians say that you have saved me at least 5 minutes per patient, because I've got all the information that I need without having to sift through documents on DocMan and disparate systems, logging on to another portal. And that is golden for us, because that means every 5 minutes saved times so many patients per session, per day, per month. I can actually put my name on it that we have potentially reduced a lot of clinician burnout as a result. We're also sharing images as of Monday. That reduces the need for breaking CDs by cab from one hospital unit to another, or the patients having to request their CDs and taking them across, surgeons and other clinicians being able to make decisions faster. So I think we've added value in terms of patient safety there. Mm-hmm. We have reduced the amount of, this is from one of the chief nursing officers, their medication errors have reduced because they have forward visibility and backwards of what medications a person has, so that I don't duplicate prescribe and I don't prescribe anything the patient's allergic to. And we can do medication reconciliation at the click of a button. So all these measures at a national level add up to a lot. We are currently trying to put it in terms of dollars as well, to see how many times has a clinician changed his or her behavior, not ordered extra tests just because they didn't have access to the results from the previous ones. So that is something we're currently doing with a professor in Miami and publishing quite soon. So yes, the answer in the short is yes.
Good. So it works. It works. Katherine, like to bring you in now.
Yeah, I just wanted to pick up on a point that Shane made, actually. And I've seen this in so many other industries as you're moving towards digitization, is that you need to earn the right to innovate. And actually, whilst you've got, I think you mentioned key cards, 30 minutes to actually log on to a system, so nobody will log in and out of a system to make sure the right data is recorded by the right person, because it will take them half an hour to get back in. When you've got places, or I went to so many hospitals where they put an EPR in, but there was no Wi-Fi and there was no internet connectivity, so clinicians couldn't actually access and use it. So I think there's a real thing that I find really weird in the NHS, is that seem to be obsessed with artificial intelligence and obsessed with really kind of like cutting edge technology, when actually fixing the basics would give you that right to innovate. And it gives you the right to go down and sit with clinicians, as you've described, Rahul, and say, right, okay, you've got a modern and clean environment to work in with the basic technologies that you would expect. Now let's think about process automation. Now let's think about further digitization.
Thank you. Thank you. And I'll just bring Shane in.
Just building on what Rahul was talking about, and it's fabulous to hear, you know, the adoption of shared care records, the sharing of images and things, because frankly, that's what clinicians need to treat the patient, and it's what patients really expect. And I've experienced everything that you've said there, Rahul. You know, having to get your own CD and take it between your doctors is, in this day and age, is crazy. The thing that I wanted to help demystify, and this builds on the open-mindedness. I think very often if you hear of a thing from somebody else, you think it has credence. And if you hear of it twice, you think it's absolutely in stone. And that is the challenge around interoperability and integration. And this is the thing that I've been working on pretty much actually throughout the last 20 years, but the last 2 or 3 years, I've gone from interoperability to actually data. And that is collecting data from many, many sources. So if you think of interoperability, we're kind of trying to do this with systems all the time and share data backwards and forwards. And we kind of do it a bit, but there's so many complications. So what we do is we take the data and put it into big sort of data lakes and actually normalize the data so it can be seen and used. Then we can help Rahul, where we can share. At the moment, we're focusing on data, but free text, imagery, video, multimedia as we go forward. And I think what I've been trying to preach, if you like, the last couple of years is interoperability, as we talk about it, is a challenge that doesn't look like it's going to be fixed for another 10, 20 or 30 years. Don't know about you, I don't have that long. I've spent 20 years at it and we haven't cracked it. But data is available today. And if I look at the three big technology funds in the UK right now, in England, you've got nearly £2 million for the frontline digitization, which is really just bringing up some places to an EPR that some people have been using for 20, 25 years. We're really just, you know, covering over the cracks there, and that's a big fund to be doing that with. The other one is the federated data platform, which is about 360 million, and actually all that's going to do is give you operational data. It's not going to actually look at clinical data, and that's a really natural extension, and I don't see that in any of the 9 strategy documents, or John, as per your question, any of the leadership that's talking about this either, because it just seems like too hard. And then the last one is trusted research environments, and frankly, I'm with you, Katherine, on the whole, hey, we've got an AI thing over here, we are amazing. Show me that at scale. Show me where that is. You know, I've been working with algorithms for 25 years, dosing people really safely with warfarin across 180 disciplines. Now that's really, really valuable, but it isn't cool because it isn't new. But if we can get really high standards of things, and this is why if we get really good, big, clean data platforms, actually you can apply machine learning, you can apply artificial intelligence, you can put apps in at scale. And I think the big thing that we always in healthcare underestimate is the patient involvement, their desire to be well, their knowledge of actually how they can help their own condition. And frankly, I'm not sure we've got a culture that naturally brings the patient in and says, okay, this is what's happening with you. We actually keep them a little bit at arm's length. And I think opening up, that opening of data to them will help with their involvement, and their involvement can only really have a positive difference.
Yeah, and I agree with that. But we've got to be able to answer the so what question. We've got all these data lakes, we've got this, but so what? What does it mean to the end user? What difference is it going to make to their lives? You know, and you know, we've got a really good question from Nikki Simmons, which says, with the utmost respect to the panel, how do we as a group of engaged people ensure that we do not have this exact same conversation 1, 2, and 3 years from now, and we find a pathway through? And you think of things Rachel brought up, you know, the NHS app, 22 million users, because it adds value. You know, people have needed it to go on holidays, to travel, because they need their COVID passport. What other things could we be doing? How do we make sure we're not having this conversation next year that something's happened? Rachel, can I bring you back in again?
Yeah, absolutely. So I subscribe to the same view as Katherine, which is that I think we do need a bit more top down in way, and this isn't NP Fit V2, but we do need a bit of top down. We really need to drive some initiatives around making use of the data properly. At the minute, you know, there are so many different organisations at the centre going through yet another merge and disaggregate and God knows what else. I mean, the bottom line is people are not interested. So as a patient to the NHS, I just want a service. So whether it's E, I, X, D, it's, you know, the bloody NHS alphabets are relevant. I think we've got to, you know, we've got to get a very clear strategy around what we're going after, and data needs to sit right at the heart of that. And there are some, you know, there's some relatively quick fixes, albeit they're going to be quite tough. You know, some of the big third parties, and I know Katherine has referenced EPRs in the note, EPRs, but also GP, you know, some of the GP Connect contracts. We're going to have to manage these suppliers like commercial organisations do. And if we were to tighten the pressure a little bit there and really get what we need, I think that would that would help. I think there's everything to play for, but we need to, you know, stop reorganising departments at the centre and start, you know, getting the absolute basics sorted. You know, when you go into a hospital, no one's asking for AI. They're asking for a frigging appointment. So it's yeah, it's the basics.
Absolutely. Absolutely. Craig, your comments?
I think if we look back to COVID, overnight, the NHS bought online consultation and virtual consultation platforms. They bought them in 24 hours. Yeah, some were pretty rubbish, but they were online, they were deployed, and it happened at pace. I think one of the lessons that then got, well, everyone knows about online consultation platforms now. Well, let's iterate them, let's get better. Sometimes I think, and we've often seen people, we've got to get it all right day one. That isn't how industry works. That isn't how we worked in Accenture, IBM, or any others. Get it good enough. You know, don't spend the next 2 or 3 years, going back to the question, trying to get that less 10%. Get enough in, get the impact, and as Shane says, start releasing those resources to start doing some really clever things with the tools. So I think that's one of the challenges we have, is we sometimes try to wait for everything. And the other side, a big problem, particularly around primary care, is, and I respect to all my clinical colleagues here, we often have people who believe they're experts in technology. And often they are the ones who cause most damage and most delay. And they'll try and stick the triangle thing next to the square thing because it looks pretty. An example with Accenture, we were prepared to raise 1.5 million in a large health community in England where we do predictive analytics to drive chronic disease management. We pay for it for 2 years. One of the GPs says, yeah, it's nothing special really. I know you've done it in the Basque region for a mate, say then 25 million euros, but I think I can do that on an Excel spreadsheet in my garden. So again, it's absolutely iterating things quickly, but making sure it's the people with the right skills doing it, and going back to my earlier point, who are talking in a language that's relevant to the people they're helping, not going, well, I've got this great ICD-10 and it's DCS 3V3 compliant. It's, all the stuff's there, we have the skills, just do it. And if it goes wrong, start again or iterate.
Yeah, and I think, you know, that brings in culture as well, in terms of, you know, the users being amenable to use IT systems. As someone said earlier, people hate change. You know, they hate doing things differently. And I had the same experience when I worked for IBM. I've lost count of the number of clinicians that wanted to sell me their little homegrown system. And I'm thinking, well, what do I want with that? It's not scalable, it's not supportable. And quite frankly, if you've got time to develop this, you're not busy enough, you know, stick to your knitting and leave it to the experts. But yeah, so I think culture is a big thing as well, which needs to be addressed. So sorry, I'll bring Katherine back in again.
I mean, thank you. I love that concept. I get exactly the same. I get pitched with so many clinician developed small little bits of apps and AI and stuff. It's extraordinary. But I'm just going to come back to this fix the basics as well. Again, because the national infrastructure that we need, like an EPR that works, like a data platform that can work, like an NHS app, doesn't mean that individual hospitals or ICSs or ICBs can't actually tailor that to the population that they work with. And that's the thing that I just found quite infuriating, actually, is that everybody believes that digital is their bag. They all want to develop their own thing. So you just end up with little balls of mercury just all over the place with nothing connecting up at all, with constant initiative itis, and that's from the center and at each level of the organization. So everybody's innovating over stuff that should just be so easy to do. And so I think if we could just have a buy-in to just some basic central infrastructure and really simple platforms, then you can be creative as you want, and personalize and localize those to your needs. But there has to be that we have to stop wasting money on everybody being in constant project initiation and failure.
Yes. And I mean, are the ICSs a good place to start, you know, where we can really do something in health and social care that delivers real value to the patients? What do you think, Isaac? Can you see a killer app?
Sorry, can you repeat the question? I missed the last.
No, I was thinking, are the ICSs where we should start, where we can really do something between health and social care that delivers real value to patients?
I think from the conversation that I'm listening to you all, the experts here regarding NHS, what we basically need is, I think it's a lack of long-term planning, I would say. So the information about what I need for one of my residents and the information for one of your patients who is coming to you from my care home, it's exactly the same. So it's a story about one person going from one setting to another. So if we can share that data without any resistance, then that would make life so easier. So for example, if somebody needs to be discharged from a hospital, you need to have a social worker coming in and doing the assessment, writing a new report in a paperwork, which needs to be sent out to the arrange and support team, and they need to send out to all the care homes in the area, whether we can admit that person or not. It's such a waste of money, and it's a waste of resources, time, unnecessary work. I think if we plan like in 10 years time, somebody should take the leadership and say, hey, this is what we are going to do. Everybody has access to the same data, make decisions based on that. That would be solvable. But at the moment, I think we are sort of in a, when we talk about the social care sector itself, there are 15,000 plus care homes and there are 5,000 plus dom care setting, and each one of them using different system, and some of them are outdated, some of them takes a long time, and most of the organizations are still using paper. So it's even though we don't hear about the complexities of social care sector, it's because it's not one setting. It's because it's owned by so many independent providers. There has to be a solution. I think for one biggest example is during the COVID time, NHS insisted all the care homes to use capacity tracker to get the data on COVID infections and COVID infection, the vaccine statistics, etc. It really worked out very well. I think we should have something similar. So if there's an urgency, if there's a leadership, these things can be done with proper planning.
Thank you. Yes, I mean, the government has brought together health and social care in name only, I would say, at the moment. We need to look at how we integrate it properly, and technology should have a good part to play in that. Rachel, you've got your hand up.
Just one super quick comment, June, in relation to what Isaac has just said. So my background prior to healthcare was central government, and one of the tools that we used was something called Wardley mapping. So it's a great tool. It allows you to create situational awareness, and we actually used it to map all of these systems and all of the contracts in government departments. And if I just explain just a snippet to give some of the context there, Ministry of Justice, when we first mapped them, had 75 different case management systems as one department. But what it allowed us to do was then literally almost fill a wall with these maps where we could look at consolidation and we could look at what we hold on to, what we invest in and what we retire. I mean, that would be a really great starting point to have a look across health and social care to, start that process of actually moving together in one direction.
Yeah, and I absolutely agree, but it's like, who's going to do this? I think that's.
Well, I'm up for it, June.
I'll put your name forward. Yeah, right. Well, sorry, I don't have time to read all the comments coming up. It's great, but a theme that I keep saying though is leadership. And you do need strong leadership to implement, massive change like this. So going back to you, Rahul, can you say something about, the leadership that led the project in UAE? Do you know the person's name? Do you know who was leading it? Do you know who was, yeah?
So it wasn't a person really, it was the Department of Health that mandated all facilities need to be connected. Now, context. UAE is very much American in terms of payments. So yes, insurance-led, it's easy to adopt a stance where boys and girls, if you don't connect to a shared care record by 2024, apologies if we don't pay you. And that helps align and win hearts and minds. That was kind of the crux of the approach, and the rest was the clinicians were involved, that this is what we are proposing. There were town hall meetings with clinicians to say, this is what is coming. Do you think it'll help? We had thought leaders as part of that project that we put in front of the hospital leaderships. So there's no room to run, really, because it's the financial pressure and the clinician's voice. And that really helps us play back. Now we are at the stage where we're playing back success stories from that project because we connected to 100% of the facilities. So it's all kind of, it has to be orchestrated so that it leads to where you want to go. So yeah, not one person, it was well coordinated right from the top, from the Department of Health and how it needs to be done.
Okay, no, thank you. But I'm guessing there's probably individuals at different places who were responsible, who had definite responsibility and accountability for delivering certain systems. Yeah,
correct.
And you've got the, oh, sorry, Karen.
We had technology partners, and then we had, so my role currently is I'm the clinical lead for that project. So I have to make sure that whatever enhancement or whatever we add on top is what the clinicians really want. So we have physicians advisory groups, we have nursing advisory groups, we bring them together, we vet our wish lists with them. We have the technical advisory committee next to us, which will tell us about the feasibility of a project, and then we roll it out. And that's how we kind of keep it very lean. We don't go through phases of consultations and never arrive at a destination. That's not how we did it. Otherwise, we would still be talking about it. And we are only 3 years old, and we're 100% connected.
Thank you, thank you. And also the incentive was there, i.e. if you don't do by 2024, you're not getting paid. That's a massive incentive. That
always worked.
Yeah, absolutely. Katherine, back to you.
Yeah, thank you. I think there's also something about where we start. So if I think about the NHS financially is challenged, although I have to say the access to money that I had when I was a Chief Digital Officer for an ICS compared to anybody working in a local authority was just absolutely extraordinary. Sometimes you could just summons it out from the sky. But let's think about the problems we're tackling, even if we thought about patient flow and administration. So the process of getting an appointment, coordinating, getting your records, your diagnostic tests, your clinician and the patient in the same place at the same time. So pure administration. We don't necessarily need to go tackling the big clinical things that are going to scare people. Basic admin. We could take hundreds of millions out of the budget by just looking at basic admin flows and using really, really simple tools that every industry has been using for over 20 years.
Yeah, no, absolutely. I mean, when I was in IBM, I used to spend time in hospitals speaking to clinicians, and they said, we don't really care about these big EPRs. All we want is the patient, the correct patient in the correct room at the correct time. Can you fix that for us? So, I mean, maybe this is simple things like that are what's going to make a difference to both the patient and the clinician. Okay, Craig, haven't heard from you for a while.
I was also thinking about, I was in Qatar for a few years leading the review of the Hamad medical programs there. And that was, you're getting Cerner, you're getting this. If you don't want to lose it, absolutely fine. We'll have your resident permit back and you can leave. Now, that all sounds great. The systems went in, but was it the best platform for them? Maybe not. Was it the best primary care platform? Absolutely not. But it went in. And what that then did is everyone's energies went into iterating the program, doing the change management, trying to make it work, even if it wasn't the right platform. And I spent a lot of time trying to fix things. And I had 450 IT projects. Most of those were trying to fix the issues in Cerner or the other systems. But what they had done, they had the platform. So they were doing the iterative improvements in pathology or in medicine or something else. So that worked really well, but I'm not sure that level of top down, use it or lose it would be welcome in the NHS, but that might be what we do need to get to in some cases.
Yeah. As you say, it might not be the correct system, but it gets people using it, and then it's easier to transition to something that is more appropriate at a later date. Absolutely.
And you actually have informed questions rather than a wish list. I've got this system, I don't like that bit, and I know, shame with IMS and ISOF, you'd have it sort of does the job, but I don't quite like that. People are having discussion on how to improve it, not as in, well, which one are we going to have? Oh, just get on with it.
Yeah. Shane, you'd like to come back in?
Just on the leadership thing, it's an example that I've used many times. I was really lucky. At the start of my career, I worked in a group of hospitals. And every year, the CEOs of those hospitals used to go and visit another hospital in the group. They never went to the same one twice. And they'd spend a week there. And on the Monday, they'd orientate themselves and they'd be shown around the site. Tuesday, Wednesday, Thursday, they'd meet with everyone from surgeons, nurses, cleaners, housekeeping, catering, and patients. And by Friday morning, they had a sense of how that hospital appeared. And by Friday lunchtime, they used to feed back to management. By Friday afternoon, management fed back to the individual departments. About a week later, they'd get some kind of summary report that went to the centre, and everyone got something. But what everybody got was knowledge sharing. And there was nowhere to hide, you know, the challenges that we've got. And what I think would just be lovely, not just in NHS, not just in hospitals, is for people that can relate, whether it's in an ICS, is to go around and spend time in other places, whether it's CEOs of ICSs going to other ICSs, whether they are leaders, as in they are very progressive ICSs, or actually they are, I don't want to use the word laggards, but people that have got more challenges. To me, if you set something that says go and visit and be open and be respectful, then that's it. If we start at the top with those leaders, whatever organization it is, I think it's more enlightening. The organization that I'm talking about were recognized as some of the leading hospitals in the world at what they did, and it flowed right the way to the front line. I was a shelf stacker in the supplies department. That's where I was, and I knew the strategy of the hospital, I knew the state it was in, and I knew that people cared about what we thought. And I was there for 5 years. It was, to this day, I still use the lessons that we learned then, and it's just a great way, because investing time in listening, if we're gonna learn from the GDEs and the blueprinting and stuff like that, someone's got to lead. Someone's got to show that they can do something strategic here.
Absolutely, Shane. Absolutely. I mean, it just matters so much. But we have this kind of like, I've seen it in the NHS. It's not invented here. They're very resistant to using what someone else is using. It's like, if that hospital's using that system, I'm going to use that system, instead of thinking, they're doing this really successfully. I could put somebody in there in secondment, and then I could bring them back and replicate what's going on. I mean, that's, you know, what you want to do. It saves money, it saves resources, but we do have this, I want to blaze a trail, you know, and I just don't know why it exists. So we're coming up to 10:02, and it looks like the chat's going nuts. So maybe, John, could you maybe, is there anything really important come up that we've missed in terms of discussion? You know, what's?
I think I would love if we could do a sort of a vote. Maybe I'll set up a poll, or get Jade to set up a poll. I'd love to just get a taste of how many people think that a single system should be mandated for health and social care, after due referencing and consultation and so on. But then a mandate should be issued for a single system, or should we continue down this route of 42 ICSs can all choose whichever they like?
I mean, is it as you know, black?
There isn't a system that can do that, John. That's
No,
unfortunate.
there isn't. You're right, but that's rather playing to Craig's point that there isn't. We're seeking perfection. Yeah. Stop seeking perfection, and let's get on with finding something that's good enough, and then make that work. Yeah. Because otherwise, the danger is we will continue to have this conversation.
Yeah, but when you look at, you know, at the NHS app, it uses all this background data from different systems. What other apps could be put in place? So it doesn't need to be one big system. It could be a patient app. It could be an outpatient app. It could be a, you know, an app for patients.
Well, you have to bring social care into this as well,
and social care as well.
Made in the chat, you know. Without that, this is just the NHS inwardly navel gazing again and deciding what it wants to do instead of doing this integrated approach. So that's. I am summarising, but the bulk of the chat has been on that sort of a theme.
Yeah, and that's where the leadership comes in, and that's where the funding comes in, because if you don't have a joint budget for specifically integrating health and social care, it's not going to happen. It won't. Sorry, can I just bring in Paul? Hi, Paul.
Hi, everybody. John, you've provided me a brilliant springboard there, so thank you. As you know, my perspective has always been on the broader context rather than just NHS. And we've been having some very interesting conversations about clinical, because that's exactly where the focus seems to land all the time, every time. And yet, pleasantly, I've heard this afternoon that there is that broader need. And a lot of people aren't interested in simply the clinical. I want to be able to make an appointment really easy. I want to be able to link my appointments regardless of whether it's with the NHS, with dental, with blah, 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 so that I can see what's going on. You know, all this basic bread and butter stuff. But then if we roll it up to the ICS level, what is it the ICS actually need or want to do? Is it they want to know the clinical procedures that have been going on in a hospital? No. They want to know the efficacy of departments within NHS. They want to see the capacity within their catchment area, not just from a health perspective, but from a care perspective as well. And all those nuts and boltsy things can lead to further bells and whistles through configuration. So in an operational and coordinational sort of sense, a single platform would be really, really helpful, because it would negate a lot of the headaches of integration, and it would be totally open and totally configurable to what anybody wanted. But the conversation never seems to get off the ground. And I'm guessing it's because of the continual focus on clinical, NHS. Let's have that broader conversation. That's all I'll say.
Thank you, Paul. Words of wisdom as always. Rahul, what would you like to contribute? Hi.
Yes, thanks. Just on the topic of a single system, I'm not a proponent of a single system. We have integrated 74 different EMRs. As long as there are set standards for interoperability between systems and people are given a choice of using whatever works for them, because you have privates, you have the NHS, you also have the dentals. Think broader. Don't think NHS provisions only. We don't want to miss any care provision that happens out of the NHS, because that's as important as what happens inside the NHS. That's the holistic picture of the patient. I would say standards, give the choice, have the systems that are on a list of the NHS or on any list that are compliant with those standards. Let people make their choices. We don't want market fixings because of one system doing well, and that would just kill anything new coming out.
But forgive me, Rahul, I'll amend my comment. Not a single system, but a single interface. How many systems hang off the back of it is totally irrelevant. But there are certain things, which I won't delve into the detail, there are certain things that have to come from a single perspective, no matter how much you want to cut technology.
Yeah, and not forgetting, integrating social care as well, and offering incentives to social care to comply with the standards and interfaces that you define on the other side, because health is the big beast with the big budgets. Craig?
I think the challenge we've got is, and I absolutely agree with saying not one single system, but one plug and play environment like the NHS app, which is going to do lots more that you have to plug into, you have to integrate with. I'm trying to integrate with one of the two major primary care systems at the moment. National leadership making that organisation actually integrate with us will be really helpful. What we've ended up with is a couple of platforms, one of which doesn't want to play with anybody else, but there are no consequences for that organisation. So you have to hit the standards, you have to deliver them, but if you don't do it, you're gone. And that's the key for me, that we can have the single standards, which we do. We have the most regulated, best standards globally, bar none. If we use them, the problem is there are no consequences for a large supplier who goes, nah, I don't think so. And I think that's one of the things we do. And that's the role for me of NHS England and NHS Digital is, there has to be a big stick as incentives and carrots. But at the moment, I'm spending thousands trying to integrate with someone who won't pick up the phone.
Yeah, that's such a good point. And we've got to make it clear to the individual purchasing units within the NHS that there are consequences for them that if they buy things that don't conform to the standards, you're on your own. Shane.
So I'm going to take issue with everybody about standards, because I've been trying to get them and work with them for 25 years and we've given up, and that's why we've gone for data. And I know, June, I know you said, look, there might be lots of data lakes, but look, I'm going to tell you an answer. If the example, Rahul, that you gave in the UAE was actually around in 2000 in Denmark, they had 100 suppliers in the country. They said you've got 12 months to standardize. If you don't, you're out. Guess what? They're all in. And here we are 20 odd years later, we haven't fixed it. And everything that Craig's just said is absolutely right, but it was said 2-3 years ago. We've had that many secretaries of state. We've had people pull in the CEOs and founders of those companies that say you can have all my data as long as you buy my system, and the Secretary of State has told him what to do. But guess what? We're 5 Secretary of States on now, but that guy is still holding the market to ransom. Now, with all due respect, without going into all the different ones, there is an example in London. I am going to say it is the one that I produce. It's called the Discovery Data Service, and we just said, give us your data, health and social care, doesn't matter what the standard is. And we normalize it, and we do 2 things. We normalize it to SNOMED, which is the international standard that the International Clinical Assembly sort of said 10 years ago, just go for that one. And yet we've still got people working on all these different ones. I'm not here to say which one's right, but what I can say is we can take data of any kind in any format and make it usable. And where we don't have SNOMED, what we've focused on is saying, right, let's come up with ontologies and terminologies and validate those. And we now have a library of over 3.5 million, and that's all open source that anyone can use. But what's really important is it doesn't matter what the technology is, but I think if we think mandate, penalize, throw people out the market, you're not going to throw 4,000 GP surgeries out the market next year because they haven't got the right interoperability. You're not. And the way to get your data, Craig, is to put it into a neutral data repository, either at ICS level or a national level, and be able to access it. And it's what we called, so the shared care records, Rahul, I've just responded to one this morning. Ireland's looking for their first shared care record, and their only ambition is to view data. Well, actually, we're working on level 3, which is view data, send data back to the subsystems, and operate, which means, the patient can be involved. You can do other things with it. And that will allow the big systems to do really great stuff, but people to connect their existing systems that might be 30, 40 years old, but have a value, and actually bring in new things. So to me, the data layer is a bridge to the future. It connects now, and it connects the future, and it actually removes some of that energy around, well, which standard are we working on? So I'm challenging that.
I can feel the passion coming out from the screen, Shane. Our man in the data lake. So we've got 3 minutes to the top there. It's been brilliant. Katherine, could you just, I know you want to speak, can you just briefly make your point? Thank you.
Yeah. So I think there's so many ways you can attack this. You can attack it at the data layer. You can attack it at the interoperability layer. You can attack it at the single system layer. But I just really want to finish on this point of a mandate. There has to be some kind of mandate from somebody to do something different. And I completely agree with the comment about NHSE having that commercial might and power. So however they choose to do it, that's the place that we have to look. And that would be my closing statement.
Thank you very much. Yeah, and you're right. It's like, who is accountable for this? Where does this lie? Where is this driven from? Because it's been a great conversation today, and thank you to everybody who's contributed on the panel and everybody who's also contributed on this chat. There's some fantastic comments. I mean, there's so much knowledge in the room. I mean, why can't we just get on with this? It's just unbelievable. So, John, I don't know if you want to make a few closing remarks. We've got 2 minutes left to the top of the hour.
June, I'd like to thank you for your exemplary chairpersonship. I think you've made a great job of a tricky one. We've got so many panel members. To make sure everybody stays engaged and with it is absolutely fantastic. I'm grateful to all of you on the panel for speaking up so candidly. We can't do it without opinions, and we need people prepared to express opinions and so on. We don't have to agree with them all, but we need those opinions in order for us to be able to reach a judgment. And finally, thank you to all of you in the audience who've contributed so fully to the discussion and through the chat and so on. I think I know what needs to happen now, but I'm not going to necessarily reveal that. I'm going to just say you can all kind of make notes of your own in that regard, and you can lobby whoever you choose to lobby in that regard. I think it's fairly clear what needs to happen from the conversation. I think Katherine Church is probably the overall winner in terms of being able to expedite what needs to happen next. Katherine says make June the next Secretary of State. Well, I'm all for that. What a super idea. Indeed,
things will start to happen.
It's already seconded that motion. There we are. Oh, and third it. And it's all happening, June. It's you, whether you like it or not.
Oh.
Yeah, I'll come and work for you.
That's it for today, Toulemond. Thank you all
Thank you,
very
and
much
please
indeed.
come along to the next Health and Social Care digital get together. Thank you
Good.
all for your contribution, and have a fantastic weekend.
Cheerio all. Bye-bye.
Bye. Bye.